Stanford University.
So first thing I'd like to say is welcome. I thought we'd talk about migraines tonight. I do a lot of work with headaches, but migraines are the most common type of headache that I see and that I think we as physicians who treat headaches see. But I think the most important point I want you to know from this slide is that no Barbies were harmed in the making of my lecture tonight. All right. So headaches have been around for as long as history has been recording anything. I mean, we have notes of headaches dating back to 3000 BC to Sumerian literature. Headache roameth over the desert, blowing like the wind, flashing like lightning, it is loosed above and below. And for those of you who suffer from migraines, you can probably relate to this, this poem. About 1800 years later, there's some documentation of one of the first treatments for migraine. And this is an Egyptian cartoon depicting the physician with a clay crocodile that is placed over the patient's head and stuffed with herbs, and the physician then prays over the patient. And this may seem kind of barbaric. Hopefully we have made some advancements in our treatment of migraine, but some of you may disagree after the hour. I'll leave it up to you to decide. I work at the Pain Management Center at Stanford University. We are a multidisciplinary center. We have physiatrists, neurologists, internal medicine doctors, psychologists, and anesthesiologists, and as well as physical therapists. And the goal is to approach pain from a multidisciplinary perspective, to provide patients multiple tools for dealing with their pain, their certain type of chronic pain. And so we're going to talk about tonight, we're going to talk about the pathophysiology, or kind of what is migraine, what do we think is causing migraine. We're going to go into the diagnosis of migraine and what we as physicians look for when we're trying to diagnose migraine. And then we're going to go into treatment. And in treatment, I'm going to cover kind of a multidisciplinary perspective to treatment. So not just medications, but also procedures and multiple different behavioral techniques for coping with chronic pain and with migraine specifically. So migraine is the most common primary headache for which people seek medical attention. It's estimated that about 12 or 11.5% of Americans have migraines. It's fairly common disease. This is a slide that shows the migraine prevalence. Prevalence is the number of cases in a population at any given time. And you can see that this only starts at the second decade of life, but migraine can start as early as the first decade of life, but peaks about the fourth decade, or age 30 to 39, and then tapers off as we get older. You can see that the female-to-male ratio is higher in some of these, but on average is about 3 to 1. I think we covered those first 3 points. The lowest prevalence for migraines is in the Asian American population. It's the highest prevalence among whites. The median attack frequency is 1.5 per month. And attacks last longer in females. Most females report, 71% of females report their headaches last longer than 24 hours, but only 50% of males report that. And sometimes the quality of the pain can change, but many migraineurs have very long headaches. They don't come and go in an hour or two. Many migraineurs have a positive family history. So oftentimes we will ask you, did your mom have headaches? Did your dad have headaches? Are you sure? And we'll kind of pry and dig and try to maybe ask you to go talk to that great aunt that you thought may have had headaches, because that's an important diagnostic point for us. We've seen in studies that 60% of migraineurs had a positive family history. That is, that they had one or more family members who had a history of migraines. And we also know that if both parents have migraines, your risk of developing migraines is 70%. If one parent has migraines, your risk of developing is 45%. Now, for those of you who are worried, oh my God, my poor children are definitely going to have migraines, I my mother suffers from migraines, and she had 3 children, and none of us have migraines. So this is not a guarantee that your children will have migraines if you have migraines, but this is just what several studies have shown. So Peter Goadsby is a world-renowned researcher in migraine. He works at UCSF. He's more of a basic scientist, does see patients. And I had the opportunity to do some work with him. And this is a definition of migraine that he has postulated. And for those of us who have spent our life in, steeped in medical literature, this is very eloquent. But if your educational background is not medicine, I can appreciate that this may seem very obtuse to you. So we're going to go through this slowly, and then we're going to break it down, and we're going to break it down a little bit more, and hopefully try to give you guys a little bit of an idea of what we think migraine is. So migraine is a hereditary susceptibility of the brain to decrease the modulation of afferent impulses, meaning afferent means incoming sensory stimuli. So it's your inability to decrease that incoming stimuli, thus permitting and augmenting the perception of pain, sensitivity to light, sounds, smells, vascular pulsations, and scalp tenderness. So if you think about everything coming in, sight, sound, smell, touch, what you normally do is you're able to down-regulate the senses that you don't want to pay attention to. For example, these lights are kind of bright right now, but I'm talking to you and we're having conversation, so I'm able to turn down the annoying light and not let it interfere. Migraineurs cannot turn down the light. In fact, the light is blinding and the sound is horrific and the smells are nauseating, and they're unable to kind of regulate those sensory, the sensory input. So to a migraineur, it feels like a perpetual sensory bombardment. And I think maybe to some of you who suffer from migraine, that makes sense. Now, why are they unable to turn it down? Probably has something due to a genetic susceptibility. That may not be all of it, and there's various pieces of the puzzle that we're learning more and more about every day. But that's kind of the basic framework the basic starting point that we're going with. Now, there's also another important piece of the puzzle that we need to talk about when we're talking about migraines, and that's the term called sensitization. So let's say that I touch my arm, okay? It's going to send a signal to the neurons in here are going to send a signal up to my spinal cord, which sends a signal up to my brain, which is saying, hey, you're touching your left arm right now. Let's say that I take a hammer and bang my arm. That's going to activate many neurons. They're going to fire really loudly. They're going to send a very loud signal up to my spinal cord, which is going to send a loud signal up to my brain, which is going to tell me to pull my arm away. You're in pain. You're in danger. And then after the sensation's gone, it's going to allow me to, it's going to say, okay, the pain signal's gone, and you can put your arm back down again. Now, what happens in chronic pain conditions is that the neurons keep firing in this. So even after the hammer is gone, the neurons continue to fire peripherally. By peripherally, I mean the arm. And that, in turn, sends signals to other neurons to fire, which sends louder and louder signals to the brain, which causes more and more neurons to fire. And so that's what we call sensitization. It is kind of, picture a domino effect. One neuron signaling to another neuron, signaling to another neuron to keep and continue firing. And in a normal case, in the case of, in a normal case of touch or maybe a slight painful stimuli, over time your body would probably shut those neurons off or be able to turn those neurons down and decrease the firing of those neurons. But in painful conditions, and migraine is one of them, it appears that that firing does not stop. And that's what we call peripheral sensitization, and then that leads to central sensitization. And so that's why sometimes migraineurs will have a headache that starts maybe right here, but over time the headache will feel like it spreads the entire head. So a lot of those sensory neurons are being recruited and all are firing kind of at the same time, sensitizing the brain. So what is that first domino? I mean, I gave you the example of the hammer on the arm, but it's usually not, you know, you took a hammer to your head and that started the headache. Some people have that case. I mean, I do have patients that had an accident to their head or a motor vehicle accident, something like that, something fell on their head. But oftentimes, there's nothing that a patient can remember that happened peripherally that set off headache. It just started one day, or it started gradually when they were younger. And this sets off the whole kind of, there's some school of thought that believes that headache is totally started from the brain. It's 100% genetic. It starts from a channel that's firing in the brain or a special spot in the brain. And some people think the domino is due to perhaps an injury externally to the brain. So one of the nerves that supplies sensation to the scalp or to the muscles of the head, not inside the brain itself. And so whatever that initial domino is, both of those, the domino will lead to trigeminal activation. Now the trigeminal nerve is the nerve, and there's a picture of it there, that supplies sensation to the face, to the scalp, to the blood vessels in the brain, to the meninges, which is the lining of the brain. So trigeminal nerve is really the most important nerve of the head. And somehow the trigeminal nerve gets activated so that it's firing. That leads to neuroinflammation. When a nerve fires really quickly, that leads to neuroinflammation, which causes that domino effect. It activates more neurons and leads to peripheral sensitization and leads to central sensitization. Migraine is a disorder of recurrent attacks. So these attacks can last for hours or last for days, and there are usually four phases that we're going to talk about. The prodrome, which is kind of the warning signal. The aura, which is an abnormal sensory experience that occurs prior or usually at the beginning of a migraine. The actual headache itself, and then the postdrome, or the aftermath of the headache. And we'll kind of go through all four of these phases and talk a little bit more about each of these phases and get more into the science behind it. So prodrome, we used to not really pay attention to prodromes, but research is getting more interested in it, because if we can figure out when the migraine is going to begin, we may be able to kind of hit it head on with medications and treat it before it gets started. So what people have noticed is that, some migraineurs have noticed that before a migraine starts, maybe in the day or the hours before a migraine starts or the evening before a migraine starts, they'll notice some changes. They'll feel irritable, lethargic, maybe increased yawning, possibly neck stiffness, food cravings or food aversions, micturition changes, bowel movement changes, and some of this is similar to changes that you experience prior to your period or your menstrual cycle as well. Now these are different than triggers. So in between the prodrome and the headache, some people say that they have triggers. So they have something that actually sets it off, guaranteed will set it off. And the number one cause that patients say sets it off is stress. Other things that set off the headache can be relaxation from stress, the menstrual cycle, which we kind of alluded to, physical exertion, oversleeping or undersleeping, meal skipping, alcohol, specifically red wine. There's been some studies on the alcohol, and it seems like red wine is really the one type of alcohol that stands apart from all other alcohols as almost definitively causing headaches in migraineurs. Diet is a little bit confusing. We're going to talk about that in a little bit. There's been some mixed data on that. Dehydration, weather or weather changes, bright lights, loud smells, strong smells, cervical pressure, that's like neck pressure, so sometimes patients who have like chiropractic manipulation or massage or acupuncture, that can set off a migraine, and greater occipital nerve palpation, that's the nerve back here that supplies sensation to the back of the head. And we'll talk about that a little bit later. So I think that one of the important things that I take from triggers is that migraineurs really need, migraineurs do the best when they can manage some of these things.